Welcome to Public Health Musings, where we unravel the complexities of public health challenges and opportunities. I'm your host, Dr. Carolyn Nganga-Good, and today we are embarking on a special series of episodes featuring contributors from an upcoming book set to be published next month, May 2024. As the editor of the book, called COVID-19 and Public Health, I'm excited to delve into the insights provided by those who have contributed chapters to this forthcoming publication. Joining us are two fantastic chapter contributors who bring a wealth of expertise to our discussion. You can find the book at Amazon and Barnes & Noble, and it's available for pre-orders as soon as you can. But first, this episode is sponsored by Okera Coffee. Elevate your coffee experience today with premium freshly roasted beans delivered to your door. Use code SAVE10, SAVE10, for your first order, or save 16 for any 3 products at checkout. Treat yourself at shopokeracoffee.com, SHOPUKIIRACOFFEE.com. So I can't hold my excitement. I'm so glad to be introducing you all to two fantastic researchers and public health practitioners. First, my friend, Dr. Carolyn Nganga-Good, a branch chief at the Division of Practitioner Data Bank at the Health Resources and Services Administration. She has over 20 years of experience in public health nursing and leadership. Dr. Nganga-Good oversees the Policy and Disputes branch, bringing valuable insights into workforce dynamics and data management. Joining her is her colleague, Dr. Adanna Agbo, the chief of the Advanced Nursing Education branch at the Health Resources and Services Administration. She has a background spanning over 2 decades also in nursing and nurse education, and she leads a team dedicated to advancing innovative nursing workforce programs, contributing over $102 million annually to public health initiatives. Wow, so fantastic. So we're all going to talk about the lessons we've gleaned from COVID-19 pandemic and focusing on the critical needs of the public health workforce, as well as infrastructure. The pandemic has underscored the importance of a resilient and well-equipped public health system, and our guests are uniquely positioned to shed light and the path forward. So welcome our guests to the show.
Thank you. Thank you.
I am so glad to have both of you here. So I will start with you, Dr. Nganga-Good. Can you tell us again your motivation for why you do what you do, but mostly elaborate on the specific challenges that are faced by the US public health system before COVID-19 pandemic and how these vulnerabilities were exacerbated by the crisis?
Sorry, I'm going to jump in. Sorry, Dr. Nganga-Good. Before Dr. Nganga-Good goes, I would like to offer a disclaimer that the information that we're going to present are in this podcast are those of our views and do not represent that of our employer. So as she continues to respond to you, I just wanted to provide that disclaimer. Thank you.
Thank you.
And thank you for jumping in. I was about to just start with that, but thank you for this opportunity, Dr. Nganga-Good, and bringing this very important topic that we saw what COVID did. And so it's important for us to talk about what happened and how can we better prepare ourselves for future, threats and public health emergencies. So to answer your question about the specific challenges that the U.S. public health system experienced before COVID and also after COVID, let me first kind of lay the foundation of how the U.S. public health system is structured. So the federal government has the delegated authority over public health matters, and then they further delegate that to the states and local health departments, which means that, different states, different local health departments will have different public health laws. And that's what kind of complicates us, our public health system, including our healthcare system. So, and also within the federal health government, there's multi-agencies that do different things. You have CDC, FDA, and you have HRSA, you have NIH, and they all kind of work together, but not quite together sometimes because they're focusing on different areas. So those are some of the complexities that our public health system has. However, it is also a beauty because every state is different. We have rural states and or rural jurisdictions and urban jurisdictions which have different needs. which has an advantage of having different, catering for different needs, depending on, the funding can be catering for different needs depending on the jurisdiction. But some of the challenges that the public health system has experienced are the bigger one, the main one, the one that drives everything is the budgets. Over years, we have seen significant budget cuts and underfunding of the public health system, despite the increased needs that we see in our communities. And also we've seen that over the years, we've had more and more, not only people are sick in the community. Before, we had people who were sick were staying in the hospital, but now we are discharging patients earlier. So meaning they have to be taken care of in the community. We also have increased burden of disease. We have newer diseases. We have other threats like bioterrorism. We have, emergency preparedness that health departments are now tasked to do. So despite all these increased needs, there's been either level funding or budget cuts. And when funding is also some funding is very earmarked, whereby it's for specific needs. So, for example, if funding is supposed to be for emergency preparedness, you cannot use it for another program that probably needs the funding. So that's a huge challenge. The other challenge that we're experiencing as a public health system is our aging infrastructure. According to our Institute of Medicine, now called a different name, in 2003, they reported that the public health system was in disarray because most of these health departments have either antiquated systems or systems that are not coordinated. When the pandemic hit, even we found that some health departments were still using paper records, or they were in a hybrid situation whereby this paper and some things were electronic, and trying to kind of merge this together was just chaos. And imagine like some rural or even some very small health departments, for example, when COVID hit, they had one fax machine, and they couldn't accommodate the influx of lab results that they were getting. So these are some of the the challenges that we have. And in addition to that, it's an aging workforce. The public health workforce is, nearly half of a good part, 20% to 30% is nearing retirement, or they're in retirement age. They're just sitting, to exit. So those are some of the issues that the challenges that we've experienced. We experienced before and were exacerbated as a result of the widespread and massive influx of cases and of COVID-19 cases, and during a very short period of time.
Those sound like insurmountable challenges, and they sound big and heavy. And I'm just wondering, I don't know, is there a way out? Is there hope, with what we've seen? I'm glad that COVID did open up these gaps and help us identify where we need to fix these challenges. But what is the timeline we're looking at here as a follow-up? What do you think?
Repeat that question?
The time that it's going to take to fix these gaps.
So luckily there was an influx of funding that came with COVID-19. So some things we were able to catch up. Some of the programs that were, for example, halted when, it was all hands on deck. So a lot of the staff were reassigned to address COVID initiatives. And therefore, things like immunization, family planning, STD, HIV testing were halted to address this. So we'll probably never know quite the impact that halting or stalling of some of these programs had, but some have recovered and some may never recover. But that is where we are hoping that with advocacy and increased public health funding, we can be able to kind of, close that gap.
So over to you, Dr. Agbo. What do you think are those key elements of a resilient public health workforce? And how can investment in this training, given all that money that was put in, when we train and help in the development of this workforce, how can that contribute to this resilience?
Thank you for that question, Dr. Kingari. So as Dr. Nganga-Good talked about, we had challenges, and we still do, that, of course, we're exposed with the pandemic. And one of the things we recognized was key was the importance of the workforce. we saw that we couldn't do this work without the workforce. And I like that we're having these conversations because there has been, the way we value the workforce has varied. So when you talk about resilience, some people look at a resilient workforce as those who can thrive in unpredictable circumstances on instead of just surviving through, instead of just getting through it, but they can actually thrive and they can come out of the on the other side, as we can see where we are for, coming out on the other side of the pandemic, looking back and saying, what was it that helped us thrive through, and what can we do to even get better? So some of the things to consider is just to think about in terms of the resilient workforce. I look at it in under two classifications: the external and the internal. So some of the key elements is to look at what are the external elements and what are the internal elements. What are some of the things that we can do to ensure that we have a resilient workforce? So what kind of trainings do we need? What kind of preparation do we need for the workforce? What kind of support are we providing? And actually, one of the main ones that is near and dear to me: what kind of compensation are we providing for the workforce to encourage more of the public health workforce to be there to do this work as much, and also have job satisfaction for the work that they're doing. And Dr. Good and Nganga-Good and I have been talking about this idea of a value-based public health, right? To think about the work that public health provides and understand the value of it and compensate accordingly. And the chapter that we wrote in the book talks about the benefit, the cost benefit for the work that public health does, which sometimes doesn't get highlighted. So to think about those external factors is when we're investing, like you said, what are the key elements and how can we invest? When we're investing, we need to think about how are we investing in the salaries? How are we investing in the compensation? How are we investing in the type of training that is needed? What kind of training do our public health workforce need? And then coming to that internal side of things, most of us have gone into public health to change the world. I keep hearing that sometimes, as cliche as it sounds, we still think we can make a difference. So there is that internal piece of building a workforce and creating our culture to let public health workforce know, as we continue to create the culture, for where the workforce operate, is to say, we are here for a purpose. We're here for a mission. We know what we're doing. We're dedicated to getting this work done. So in terms of that investment, and this may not be necessarily investment in funding, but perhaps investment in people, is to look at investing in the physical health, in the well-being, and investing in people being motivated to even get that work done. And Dr. Nganga-Good talked about awareness. And when we bring awareness, not just to the public, but also to the workers themselves, to know we are making a difference and we want to keep making a difference. Thank you.
That's amazing. I liked two things that you pointed out: the intrinsic value. I tell my students all the time, we're not going to get rich from just being in public health. Many of us come into this field because we want to make a difference. But I appreciate your perspective that even in making a difference, people need to earn a good income so that they can live optimal lives. And often it's finding that match where you're going into this thing that you like, but you're also able to live and work and be excited at the same time. I don't know if you guys have thoughts about that. Any additional thoughts?
I do. I do have thoughts about that. All of us want to be valued as human beings. There is an intrinsic need to feel valued. And I know that compensation, as much as it is good for optimal living, but it also resonates as value. It's saying, I value the work you bring, so I'm going to compensate you. So that brings the joy in the work. As much as I'm doing mission-based work, I'm also being valued in the work, and actually lets me know, yes, I'm valued, and this work I'm doing is also equally important. And that speaks to supporting my ability to stay resilient, even in the face of something like the pandemic, like we saw.
And as someone said, actually, during one of my conversations with some young students, that wanted to work in public health, they wanted to be public health nurses, but the pay was just not, especially at local health departments and state health departments, was not just making sense. And one of them, we were talking about it, and I said, it's true. Passion does not pay. It doesn't pay my bills. So the reality is that, especially education is expensive. So a lot of students are graduating with student loans, and therefore they need a job that helps them to feel fulfilled, but also helps them to be stable financially and sustain them, and be able to pay their bills. So we cannot say we're going to do this mission work and not be able to compensate folks. Something gotta give.
Indeed. And speaking of compensation, speaking of value, there's always cuts, right?
Yes.
And public
Yes.
health suffers from, first of all, not getting enough funding. But then now in your chapter, you talk about the significant cuts to public health and staffing since 2008. So, Dr. Nganga-Good, how have these reductions impacted the ability of public health agencies like yours or others to respond to both ongoing and emerging health threats? And in my mind, I'm thinking of health departments too.
Yeah. I'm glad you asked that question. And actually, this is one of the things that I'm very passionate about: is how do we sustain public health with the funding that we have? So with budget cuts comes reduced staffing. So let's start from there. As Dr. Agbo was talking about, like, staffing is the core of providing those services. You can have the systems, you can have the support, but if you don't have the people to do the work, then it's not going to get done. So one of the biggest impact that some of these funding cuts have impacted is just inability to have enough staffing. We experienced a lot of furloughs, a lot of layoffs, hiring freezes, and sometimes when jobs are vacated, they're eliminated. They're not. They don't hire people for those positions. That means that people are working with less, and despite of the increased needs and loss of historical knowledge. With all these people leaving. And as I mentioned earlier, a lot of the folks are in retirement age. So as they're leaving and their positions are not being replaced, or they can't hire soon enough to be able to transfer that knowledge, we are having all this historical knowledge losses. And this is loss of some very critical positions. For example, like, leaders, when during the pandemic, we saw top level officials either resigning on their own will or being forced out or for whatever reason. So you can imagine during that time when you're losing such critical positions and there's no leadership during a crisis, that can lead to a lot of problems. The other things that the budget cuts also impact is the limited resources result in you don't have funding for enhancing your infrastructure. For example, information technology. We've talked about antiquated systems and systems that don't talk to each other. Without funding, and we know IT stuff is very expensive. So if you don't have money to pay for this enhancements, then you have systems that are either vulnerable to hacking, to cybersecurity issues, or even systems that relying on paper records. And we know what paper records can do is that during the pandemic, no one can go to their office, or very few people are going to their office. So you don't have access to documentation, or you're not able to coordinate care appropriately because systems are just not talking to each other and they're not synchronized. But the other thing that funding cuts has resulted, and we've seen nearly half of the health departments reported that they had either eliminated their programs or reduced their programs. So without funding, without staffing, without this supplies and equipment, you end up closing some of the programs. And some of these programs are the safety net of some of our communities. So, for example, a community that relies on their health department for their healthcare, for their immunizations, for their family planning, for their testing, for their screenings. That means if you eliminate those programs, then those communities are not getting care. For example, there was a case I'm not going to say the state, but there was a state that eliminated their maternal child programs, their home visiting program, and they saw a tremendous increase of infant mortality rates in a very short period of time. So these are the things we are talking about, real impact that results from these cuts. But again, if it's not prioritized, there's no political will to actually fund public health, then these things just fall on the wayside. And there's often confusion about the monies that come through the acute care system versus the money that is in the public health system. So we have to balance, because both systems have their role, And, with public health, you're talking about prevention. You're talking about assuring there's some services that cannot be done by the acute care side of things. You're talking about inspections and all this regulatory stuff that needs to be maintained to ensure that we have a good public health system. So these are some of the challenges that elimination of funding or level funding, especially with increased needs, results in. And we often don't talk with public health. We don't often talk about like the school system. The kids in our schools now are sicker than ever. School health nurses are not just doing band-aids. They're taking good care of children that have maybe vents. Some of them have not vents. I'm sorry. They have trachea tubes, or they have feeding tubes. And so, how do you manage these very sick kids? And also imagine threats that are coming from our climate changes. Like, for example, we have kids who have more asthma. They have to get their puffs nebulizers every so often. So it just requires having people to do the work. And when you don't have the people, when a school nurse is covering 6 schools, she's not able to do the work that she can be able to do it effectively. So we need to think about how do we provide people with the resources and the tools that they need to do their work effectively and to do it well.
Wow, it can be depressing, when you hear about these cuts and the lack of enough staff, but yet all of us need adequate health, right? All of us need adequate education. We need the right environment. This month is Maternal Health Month. And, you brought that up when you hear about funds being cut for such critical programs, especially when the United States is leading from behind when it comes to maternal and child health, particularly among, Black women.
Absolutely.
It is sad. It is sad,
But there's always hope. And we
There's
see
always
people
hope.
wake every day and go to work and still do it. But it really does impact, prevention and well-being overall.
Yeah. I don't know if you have additional thoughts to that, Dr. Agbo.
Um, I think it goes back to the value and the understanding about the need, and we have to start having conversation. I think maternal health is one of those things that is starting to make us wake up. And it's interesting, and I'm going to be short with this. It's interesting that we're talking about this issue about maternal health, whereas we were having this conversation close to a decade ago about the maternal mortality issue in the US. Close to if not more than a decade ago, because I can distinctly remember in a class where I was learning this and talking about the Black women were at that time 2 times more likely to die than their Caucasian counterparts. And we had that conversation. Public health was in front of that conversation saying, can you guys see what is happening here? We need to start doing something. It took us as a nation at least more than a decade to finally wake up and say, okay, this is a problem. Let's put some money behind this. And I see that's what we're doing with public health. COVID tried to wake us up. As much as COVID had negative and dire consequences, fatal consequences, COVID said, come and take a look at your public health system and see what you need to do to make it better. And I'm hoping that and that's the hope that Dr. Nganga-Good talked about. As we think about these cuts, I hope that those in positions to make decisions about policies and budgets and finances and funding and support get to have a conversation and talk about and consider the impact of what reducing funding or leveling funding to the public health infrastructure and the public health system, what would be the consequence of that? And maternal mortality is one of the areas we can see this impact of that. And so I'm hoping that we start to have those conversations because, like Dr. Nganga-Good said, there are some things we can't do in an acute care setting. There and public health, really, those local agencies, those local health departments are sometimes a safety net for care for those communities. And we have to start to recognize that. So thank you for allowing me to chime in. There's so much to talk about budget, but thanks.
Yes.
Yeah. I mean, sometimes it just becomes a little bit exasperating, if you will, or exhausting to have to go back and talk about the same thing over and over, and wondering how much more can we quantify this in terms of quality of life or years lost, right? And I want to follow that up with a question for you, Dr. Agbo. So in your chapter, you talk about the modernization of public health data and information systems. And what do you think are those specific improvements that are needed in those systems? And how can they enhance the effectiveness of the efforts that we're trying to discuss here?
Okay. Thank you. I like the book, and I like this chapter because everything kind of comes back. It circles back to the same themes we've been talking about. Cuts, infrastructure, systems. One of the examples we provide in the chapter, it shows an example of a case in California where the local health department had to be the lab had to donate a fax to the local health department, who did not have the infrastructure they needed to receive, to receive the test results for those individuals in the communities they were testing. So that in itself, when we talk about data and the modernization of data, we have to start to acknowledge the inadequacies within systems. And so when we think about that, we first of all start from a place of, does every public health agency have what they need to conduct business in this 21st century that we're living in? Most of us have smartphones, not all of us. Most of us have access to technology, QR codes and AI and this and that. Where is public health in that space? How have we carried public health along? So when we talk about systems, we talk about there is a need to modernize systems. There is a need to ensure that systems that we use in the public health space are interoperable, so that if I travel and I go to a health clinic in Missouri and I get tested for something, then I should be able to perhaps maybe even go to another health clinic in the same Missouri, maybe a different health department. And I should have that information follow me so that I'm not getting re-prescribed medications, so that I am not getting another diagnosis that I've been diagnosed before. We do this in the private sector. We do this with acute care, where if I go to an urgent clinic, for example, before you know it, my primary care doctor knows and has information about that visit. So we need to start thinking about this for public health. We need to start thinking about being able to have systems in place that are interoperable. We need to have systems in place and ensure that they're interoperable. They also have meaningful use. We need to ensure that these systems are flexible and malleable to adjust, especially we saw that with COVID. Are our systems set up enough to be able to receive the amount of information that it needs to receive? Dr. Nganga-Good talked about security earlier. Are these systems secure enough that they're protected against attacks and things like that? The other thing about our systems in public health is also thinking about those systems being standardized and synchronized so that they're providing the same level of quality data that is actually needed. One of the things that I found out the other day, and I think it's something we need to deal with as a country, is, for example, up until a certain time, American natives were being referred to as other in some data sets. And that is something we need to start to say. We need to build systems that ensures that every the information being provided is quality, is diverse, is inclusive. It recognizes the need, so that we have systems that are able to help us when we're looking at those public health core functions of assessment, policy development, and assurance, so that those systems are able to respond when we need them to. And we saw that with COVID. So I'm hoping that we can definitely take those lessons learned through COVID and enhance them further. Thank you.
Fantastic segue to what else I wanted to talk about. You bring up those core competencies. It's the first thing I teach my students in my introduction to public health. And theoretically, it sounds so good. But then practically, what your chapter talks about is the implementation is not as easy. And because of all these challenges that you've already outlined. And so for you, Dr. Nganga-Good, if you could talk a little bit about those core competencies of public health professionals. What are they? How can they guide the efforts to restore and develop a skilled and competent public health workforce in the face of these ongoing challenges?
Good question. Thank you for asking that question. But before I talk about the core competencies, let me talk about the systems a little bit. Interconnected with systems is the data burden. So if our systems are not working and we are having to collect the data by paper or in multiple systems, that means people get burnt out and they don't get to do it. But when we modernize our systems, then we are able to, automate the systems whereby it's more efficient. So that is another thing that people have to be thinking as we enhance our systems is how can we reduce the data burden that folks have to collect data, because public health really heavily relies on surveillance data, on the data that is collected to be able to even make data informed decisions. But going back to core competencies, so public health competencies are hinged on three core functions, and Adanna kind of mentioned, Dr. Agbo did mention them, the assessment, the policy development, and assurance. Those are the core functions of public health. And underneath those, we have the evaluations, program monitoring, and, diagnosing and investigating, informing the public and educating them, mobilizing the communities and, working together. So these are core competencies that should be taught not only in school, but also emphasized in the in the current workforce, because we teach them, they are taught in school, but how are we ensuring that there's continuing education for our workforce? Because to be able to have a well-prepared public health workforce, I would say the system, that includes our workforce. We have to invest in our workforce. We have to have a well-trained and competent workforce. And I would like to add also a diverse public health workforce that is able to meet the diverse populations that we serve. So how do we get to do that is by making sure that not only that the training is not only, there's a pipeline of education from when we are training new professionals, but also keep making sure that the professionals that are already in the field have continuing education. And one of the barriers that I heard from some of the local health departments, going back to the budget cuts, is that I can't afford to pay for conferences. I can't afford to pay for continuing education units. So a lot of the health departments do not have funding to support their employees to do that. And because the employees are paid so little, they don't see the value of investing in it. So it's ensuring that we have accessible continuing education and also ensuring that we have this pipeline of partnerships between the academic side of things and practice. And that is one thing that nursing and public health is doing very well, is making sure that we have academic practice partnerships so that we can be able to kind of translate both ends of the training. So you're not only getting the theoretical side of education, you're also getting the practice, the practical side of things. The other thing that I would say that we can invest in with the core competencies, so we have the 2021 updated core competencies that were released, I want to say recently, not too long, a couple of years ago. But it's making sure that there's increased awareness of these competencies, not only in the academia, but also in practice, and ensuring that the people who are leading some of these agencies, I don't want to say they're not competent, but for you to work in a field, you need to have an idea of, of what you to have some skill sets and competencies to be able to lead an organization. We've seen that sometimes just because someone may be successful in a hospital setting does not mean they're going to be successful in a public health system. They are very different and things work very differently. So it's ensuring that even when we are hiring people, despite having limitations of who we can hire because of the salaries, that we are hiring competent people. And when they come on board, that we are training them. So it's investing not only, it's also investing with onboarding training and also continuing training when they come in. The other thing, so how do we address some of these emerging threats, and like what if something as widespread as COVID comes up? 9/11, for example, when it happened, it was localized in New York and two other places, DC and Pennsylvania. So surrounding communities were able to come help. But with COVID, it was so widespread that basically you're on your own. So kind of help yourself. So how can we have a ready workforce that is readily, we can be able to kind of, what is it called, mobilize them quickly, and that they are prepared because they have the education, they have the training, they have the skills and the knowledge to be able to quickly deploy and be able to support some of these things. So if you're retired, or you're maybe working in a different setting, or you're an administrator, but yet because you have been keeping up with your continuing education and your certifications, you're able to be deployable when there's a public health emergency. So it's thinking about public health corps. Some jurisdictions have them, some don't. The federal government has the public health service, but how can local communities also invest in having these workforces or corps that can be easily and quickly deployed when we have emergencies? But I think it's that partnership between academia and practice that we need to really hone on.
Yeah, I really appreciate you saying that people who are retired or no longer in practice, that they should try and keep up with the certifications. I hadn't even thought about that. I'm like, when you're, because you sometimes you get so worn out, you just want to go and disappear. But I like that you brought that up because I think it's pertinent. And Dr. Agbo, I don't know if you had any additional thoughts to that.
The only thing I want to plug uh, is that there are 10 regional public health training centers. And I say that because we've talked about budget cuts, we've talked about limited infrastructure. There are resources out there, right? We talk, local health departments. There's also, non-governmental organizations that offer support or have funding from other sources that can augment what the government organizations are doing or what the public health space is doing. So I say, there is a plethora. We're living in a society where there's a plethora of resources and support available. Yes, we're grappling with some limitations and constraints, but there's also some, like you said earlier, Dr. Good, hope. There is also some other things out there going. So I'm putting a plug in for the regional public health training centers because they are a great source for training, for increasing that training and development of the public health workforce across the nation. And that's something I believe anyone listening to this podcast could check out. Anyone in the public health space could check out if they have not already done so, to see how they can plug in and perhaps, take advantage of some free training that could help them to be competent, that can help them to continue to be resilient, that can help them to continue to do the work they love to do, and have that as a support as they do that work.
That's a fantastic plug.
Thank you.
I love me a free training somewhere. There's always room to get new information. And with the changes that we experience in health, it's such a moving target, So there's still so much more that we have to stay updated about and on. So as we close down the podcast today, as we're thinking about the recognition and importance of public health, and I think we've harped that accordingly. Dr. Agbo, what strategies should be prioritized to advocate for increased funding and support for public health initiatives? This is what helps us sustain what we already have. So we've talked about the budget cuts, but how do we convince our policymakers and the people who make those decisions that we need additional funds, And yeah.
I will start with the word partnerships. I will start with that word because I see that word as if I were to start with, power and numbers, it may not mean much, but when you talk about partnership, that becomes a strategy. The strategy then becomes, can we come together as public health practitioners, nurses, doctors, epidemiologists? Can we come together and form alliances and partnerships that then can raise awareness and raise our voice and have a unified voice of advocacy for the needs of what we're discussing that is in this book, this amazing book that's about to come out soon, of what we're discussing that's in this book, because that's when then we can drive change. I like an illustration someone just did recently, and she said, that we're moving doesn't mean we're making progress. We can be moving in place. Doesn't mean we've taken a step forward. So, the idea is that we want to take a step forward. We want to move the needle, as they say. So in that, there is a need to increase awareness about the needs of for public health, to make the case for compensation and value-based care in public health. We have to do a better job of talking about the cost benefits. Let people hear what that is and what the consequences are if we don't do something, as we have seen with what's going on with maternal mortality. The fact that we, don't address it doesn't mean it goes away. Eventually we would have to face the issue. The other thing I do want to talk about, and I'll bring us back to that place of partnership, is that health is a fundamental human right. And we know that public health in its core is the provision of health for the public. It really is in its name. So if we think about it that way, then we start to recognize the importance and the need for public health to be sustained, to be modernized, to be supported, to be elevated. So if we do that, then we say, how do we then come together to do that beyond political will, beyond bipartisan needs or stances, to say, can we come together as a unified front? Can we come together, no matter if you're working on environmental health or climate change, right? Or reproductive issues and immunizations, child health, maternal health? Can we come together to say, as a unified voice, whether you're working at a state level, federal level, local level, non-governmental, can we come together to then start to talk to our legislators, our policymakers, and say, these are our needs, these are our priorities. And I believe in building those partnerships and those alliances, we can start to make some kind of roar and some kind of movement in getting our voices heard and getting those needs being met. And that's it. And I know Dr. Good may have something spicy to add.
Like, where's the offering back? I need to give an offering. You just preach it.
I mean, you just went for it. So nothing much to add, but I would also emphasize about messaging, because I think as I'm getting more and more comfortable with advocacy, I have realized that we do not tell our story. How do we get better with telling our story? And also customizing our story to the audiences that we are talking to. If I'm talking to the public about public health is everything that we experience every day. You woke up in the morning, the water you brushed your teeth with, it's because there was some public health that ensured that that water was safe, the air that you breathe is safe, the car that you took, seatbelt, that's public health, making sure that you're driving safely. And there's all these things that sometimes I think we don't associate with public health, and we just kind of think about, family planning, the immunizations and stuff like that. But we have to remind the public that public health is everything that you do day in, day out. And then when you're talking to your legislators, they're just interested with the bottom line. What's the cost saving? So it's articulating how will you cutting this budget for example, for maternal child services impact maternal mortality, infant mortality. So it's, I think, articulating those stories in a way that each audience understands them, and it's also focusing on what they value. The legislator is going to be thinking money. The bureaucrat is thinking, how is this going to, a politician is going to be like, how does this look, on me? So it's thinking, customizing those stories and having that unified voice as the public health community, despite the different fields and focus areas that we work in. How can we unify our voice to advocate for public health in general?
Man, what can I
And one more
say?
thing, it's also sustainable funding. Like,
Yes.
thank God for the COVID funding. We had an influx of, with the emergency, we had an influx of funding. But now the emergency is over, the funding is gone, and the huge gaps that our health departments and our public health organizations are experiencing is tremendous. So what happens to the gains that we have just started to get, and now the funding is gone? So it's also thinking sustainable funding.
Wow, this has been amazing. I have learned so much. I mean, every day I just smile. I wake up, I'm like, I'm so glad I'm in public health. There's so much to learn. It's everything we do, like you said. That was my first episode in the podcast. We learned that public health is everything. And I just wanted to give both of you just another chance as we close down. Is there anything else that's burning inside you that you want to let us know, even as we end this podcast today?
I will go first because Dr. Nganga-Good knows how to wrap us up. So I'll go first because my brain does one of these and she brings us back in. One of the things that came to me as she was talking about the stories we tell, and I just finished my participation at the 2024 Association of Public Health Nurses annual conference. I've just been so inspired, is conversations about the view of nurses or public health nurses during the pandemic. And this notion that the work of public health impacts our daily lives, I think we definitely need to drive that home, because a lot of the opposition came from you're telling us to wear a mask, you're stepping on our amendment rights. But there's a lot of things you do that were because of the public health practitioners that advocated for your health and your safety beyond the mask. So it was almost like a separate thing. You became the healthcare workers became this pariah, so to speak. So we need to definitely take a moment and reclaim and tell that story well, and reclaim the prestige and the word comes to me is respect. I'll say it. The prestige and the respect of public health workers. And because we are important to the health of the nation, and the public needs to know that. And I think once we have, on our side, the public, it helps us make gains in being able to advocate then for the continued and the sustained support and funding and all that we need to make, to make this work better and then to better serve communities that we're in. Thank you.
Yes.
Thank you so much. You summed it up. What I would say is that public health works, public health saves lives. And so therefore we need to really consider investing more, sustainable investments into the public health system. And that includes providing a conducive work environment for the work to even happen. Because when as we are saying, if you don't have the people, the work is not going to get done. But you may have the people, but if you don't also have a conducive environment whereby they have the resources and the tools that they need to do the work that they need to do, then it's not going to happen. But above all, it's also going to that fundamental belief that health is a fundamental human right. And so that public health is not just for the poor, public health is for all of us. Because I think there's sometimes the mentality that public health only benefits the poor, and therefore, why should we care? Public health benefits all of us. As we've said, public health impacts our day-to-day lives, and public health is in everything. So we need to really wrap our heads around that public health is not for the poor, it's for all of us. And therefore, we need to really have the political will and also be willing to have sustainable investments to make sure that it's, that we have the systems that work and that are ready to, address any threats, emergencies, and day-to-day needs.
Fantastic close. I mean, if nothing else, today we've learned that public health is a fundamental right. Okay. Everybody, everything we do, the water we're drinking, the food we're eating, it's all of it is public health. And as we conclude, I just want to extend my sincere thanks to both of you, Dr. Nganga-Good and Dr. Agbo, for just your invaluable contribution to this discussion. Your chapter in the upcoming book, COVID-19 and Public Health, everybody's here. Yeah. Provides essential perspectives on the lessons learned from the pandemic shaping the dialogue around the revitalization of public health workforce and infrastructure. And as you've seen from this podcast, we didn't just talk about COVID. COVID was just a catalyst, right? To looking at some of the issues that have been there for a long time. So we are saying that, yes, we were in this phase of COVID, but public health continues. And now that we are back to where we were before, that's not how it should be. So my hope is that this episode is just the beginning, okay, of how else can we make public health worthwhile and sustainable, and also an introduction to the other chapters that are in this forthcoming book. Again, it will be published next month. So join us in the upcoming episodes as we continue to interview contributors and delve deeper into the pressing issues facing public health. And as shown by the gaps that COVID-19 was able to reveal. Thank you all for tuning in to Public Health Musings. Until next time, I'm Dr. Carolyn Nganga-Good, and I'm urging all of you to stay engaged and stay informed and stay committed to shaping a healthier future for all of us. So until next time, thank you all for joining.